Hi everyone, I'm Dr. Tracie Linhart, Medical Director of Peaks of Health Metabolic Medical Center. Tonight we're going to discuss thyroid. Backstory on thyroid. No, I was an ER doctor for many years and I was thinking I had a thyroid issue and was told by my primary care that there was nothing wrong with my thyroid, that everything looked good. And I kept on swearing, for a couple of years that I had a thyroid issue. Finally, I was like, I am wearing socks in Florida in July because my feet are so cold. I'm pretty sure with all my symptoms, I have a thyroid issue. So I started really learning about thyroid and realized that as physicians, in many cases, the only thing we do is look at a thyroid stimulating hormone or TSH, which is inadequate to look at someone's thyroid when they have certain conditions. So hopefully we'll teach you here some of the symptoms of thyroid to see if that may be you and how we actually evaluate thyroid and how we actually treat thyroid. So this is your actual thyroid gland. And so it sits in your neck. So we actually palpate people's thyroids. So we find a lot of nodules on the thyroid. We found thyroid cancers that went undiagnosed by palpating the thyroid. So we do this on every patient that comes into the office, regardless if they're here for thyroid or not. It's just part of our normal physical exam. These are the actual hormone pathways. And this, where this becomes interesting is we are taught to measure something called TSH or thyroid stimulating hormone. It comes from a gland in the brain called the pituitary. It's not your actual thyroid hormone. This is the signal that tells your thyroid to make thyroid hormone. So when the TSH is high, the body perceives that the thyroid is low. When the TSH is low, the body perceives that the thyroid is really high. So it's a feedback loop. So it's not exactly always an accurate measurement of exactly what the thyroid is doing. The thyroid gland makes something called T4 and T3. T4 is like a 7-day storage of thyroid. So you have enough thyroid to convert over. So about 80% is made as T4. T3 is the active thyroid. So you do make a little bit of active thyroid. And then the rest of it you convert usually in your liver. So some people may have normal thyroid function, but they have what we call secondary hypothyroidism because they're not converting their T4 to T3. And this happens more as we age and with other medical conditions. There's also a condition where you can make something called a reverse T3 that we'll talk about later too, which inactivates the thyroid gland. This is what a lot of my patients think. It says, why do you call it a thyroid problem when it gives me an excuse for the extra 20 pounds I gained? Well, a lot of my patients, when they're gaining weight, they always think it's a thyroid issue. In many cases, it may be. In some cases, it may be some other issues. So we look for all of those causes. Some simple facts about thyroid that you may have heard or may not have heard. So I have a family history of thyroid disease. So having parents, grandparents, siblings, children with thyroid issues can possibly increase your risk of thyroid disease. Gender, women, much more than men. One of the reasons for this is, especially in menopause, is that there are thyroid receptors on our ovaries. Men don't have these same thyroid receptors on their testicles. So because of that, women have a higher rate of hypothyroidism than men. Age. As we age, we don't convert thyroid as well. And thyroid is like a gland, like any hormone. It can go down with age. And then hormonal changes. Again, women with postmenopausal changes, a lot of women become suboptimal thyroid at that age. And then autoimmune disorders like Hashimoto's or Graves' disease will affect the thyroid gland. Thyroid, what does it do? I kind of explain it to a lot of patients as it's kind of like the master gland of how fast and how slow things operate. So it's a body regulator. Thyroid hormones stimulate the cellular energy, which means how much energy you have. That aids for the function of mitochondria. Mitochondria are nothing but basically the powerhouse of your cells. They're the batteries that operate everything. We maintain our body's relative temperature, which is why when you're low thyroid, you usually have a low core temperature. And when you're high thyroid, you usually have a higher temperature. It affects tissue repair and development. So how well you repair everything, how fast everything works. Functions with the liver and clearing out harmful waste. So again, how fast your liver detoxifies and how slow it detoxifies, depending on how your thyroid is functioning. Immune system is dependent upon normal thyroid function. So if you have hypothyroidism, you're not going to have as much of a robust immune system and white blood cells. And assists in digestion. So that's one of the reasons why a symptom of low thyroid is constipation. A symptom of high thyroid is diarrhea. So how fast and how slow that gut works. sorry about that. Hormones stimulate cellular, this is the same one, isn't it? Okay, sorry about that. Modulates blood flow, modulates carbohydrate, protein, fat metabolism, modulates muscle and nerve actions, sexual function. So hypothyroidism is one of the things that can affect sexual function. Regulates vitamin usage, how well you absorb nutrients, stimulates protein synthesis, hormone excretion, and how you eliminate some hormones, and oxygen. So again, one of the things I say is it's responsible for the speed of every cell in your body. What are the thyroid hormones? What do they mean? So TSH is thyroid stimulating hormone. As we said, this is from the pituitary gland. So it's kind of like the master feedback loop. So it's how, again, our brain is perceiving our thyroid is working. T4 or thyroxine is made in the thyroid gland by 80% of thyroid production is T4, and then converted to T3 in the liver and the kidneys. Triiodothyronine is T3, which is your more active form of thyroid. So this is, one of the ones we mainly look for, because if you're making T4 but you're not converting it to T3, you usually will feel low thyroid and have symptoms of low thyroid. And then T2 also, there's a T1 also on top of that. But this actually increases metabolic rate, and it also works as a mild diuretic too. So a lot of people with low thyroid may turn around and actually be retaining water. And where this becomes important is when we're using different kinds of thyroid, because most of the treatments are things like Synthroid, which is just T4. And if you're not converting your T4 to T3, you're going to have not feel that great on Synthroid. What are the symptoms of hypothyroidism? What are you looking for? Well, since it controls almost every cell in the body, the symptoms are vast. Agitation, allergies, anxiety and panic attacks, arrhythmias, atrial fibrillation, brittle nails, carpal tunnel syndrome, coarse and dry hair, cold hands, cold feet, constipation, memory issues, decreased sexual interest. Myxedema is kind of when you get fluid underneath those tissues. So if you kind of pick up your arm and the whole thing comes with you instead of the skin, that's kind of a sign of myxedema. Depression, hair loss, dizziness and vertigo, drooping eyelids. There's tons and tons of things. Increased earwax is one of the surprising things I found. Fatigue, obviously, a lot of people complain of fatigue, weight gain, fluid retention, gallstones, women in their mid-40s and 50s. Blood pressure issues, cholesterol issues. We make our thyroid out of cholesterol the same way we make most of our hormones out of cholesterol. So when the thyroid goes down, the body will produce more cholesterol out of the liver to compensate for that. So, that again, that's one of the things that'll do that. It'll also affect liver enzymes. So you can actually have elevated liver enzymes with thyroid issues. Insulin resistance, diabetes are related into thyroid. Increased appetite, increased bruising, insomnia, increased PMS and menstrual cycles can sometimes just be related nothing more than thyroid. Joint pain, loss of hair, especially on the arms and the legs. A lot of women will just or men, but mostly women will lose their hair on their legs from that. The lateral eyebrow, the outer portion of your eyebrow, loss of that is a significant sign. That is almost, what we call pathognomonic or signaling thyroid issues. Low body temperature. If you get up in the morning and you take your temperature and it's really low, that's usually a sign of thyroid issues. Painful menstrual cycles in our younger people. Recurrent miscarriages also can be a sign of it. Sleep apnea. Memory issues, slower brain function, ringing in the ears can be one of the signs of it. So there are many, many different things that can affect it. Some of the conditions or diseases that are associated with thyroid issues. ADHD is associated, chronic fatigue, fibromyalgia, congestive heart failure. One of the incidences with heart disease, when people have heart attacks, if they have low thyroid, they're more likely to actually get congestive heart failure because the heart muscle doesn't reconstruct like it should. Depression, elevated cholesterol levels, heart disease, high C-reactive proteins, because CRP is processed in the liver, thyroid is converted in the liver. They are related. Increased homocysteine levels, which is one of the tests that we do because it's significantly, homocysteine is one of those amino acids that damage the blood vessels and can create hypertension and all kinds of issues. So we actually monitor that in most of our patients. And insulin resistance. So how do we measure your thyroid? So typically most doctors will measure a TSH or a thyroid stimulating hormone. Some may measure a T4 or total T4. We measure the free and the of T4 and T3. And the reason we measure the free is this is the unbound version of what is available to the cell. So we want to know what can actually get in, connect with your cell to actually signal it to work. We measure reverse T3 because this is the opposite of T3. So if you're making a lot of reverse T3, it hits that receptor site and it just inactivates everything. TPO antibodies and thyroid globulin antibodies are looking for Hashimoto's disease. And then sometimes we may ask our patients to measure what we call a basal body temperature. What that is that temperature first thing in the morning when you wake up before you ever get out of bed, before your body starts heating up. Again, this is just understanding the thyroid tests and where they work at. The TRH is thyroid releasing hormone. That's from the hypothalamus part of the brain. TSH comes from the pituitary part of the brain. T4 is primarily coming from the thyroid gland, and T3 and reverse T3 is primarily coming from the cellular level. So what is reverse T3 we talked about? It's a measurement of inactive thyroid. So if you're making a lot of reverse T3, then your T3 is not binding in, you're going to feel hypothyroid. And this can happen in several cases, whether you have an infection, whether certain other conditions occurred. Also in Graves' disease, a lot of patients have hyperthyroidism, and to protect the body from that high thyroid, the body will make a lot of reverse T3. It happens in, again, Graves, autoimmune disorders, under stress, toxicity will do it. Yo-yo dieting will do this. So that's why a lot of people, when they diet or crash diet, they gain their weight back very easily because their thyroid will compensate for it. And their TSHs will actually look pretty good. They'll get a low TSH where everybody thinks their thyroid's working great, and it's really not. And then high estrogen or estrogen dominance, which is an issue we're having a lot with a lot of younger people these days. These are just factors that can affect your thyroid, and it's just for you to kind of review. It shows things that will cause T4 to go to reverse T3. What becomes really important is the increase in conversion to T4 to T3. So some people that are under a lot of stress, they will be low in zinc and selenium, and those two compounds are needed to convert thyroid. So we'll actually increase, I'll give my patients selenium. I'll check their iodine levels. I'll check some of their nutrient levels. Tyrosine is really important. So if you're very stressed out, your adrenals will steal your tyrosine. And that is what thyroid is made of, tyrosine and iodine. And then we'll also check iodine levels. A lot of people are iodine deficient these days, simply because a lot of us changed to sea salt and it's not iodized. One of our main sources of iodine was iodized salt. These are some nutritional deficiencies that can occur that cause low thyroid or low T4 production. Copper. A lot of people are taking an awful lot of zinc, and zinc and copper are very in tune to each other. So if you go too high in zinc, you'll lower copper. So either one can be affected. Vitamin A, B2, B3, B6, and vitamin C. And vitamin C is one of those nutrients that the adrenals use a lot of. So your stress glands will use a lot of vitamin C. So stress is one of those things that will affect thyroid. Factors that affect conversion. Different, lead toxicities, mercury toxicities, people with, mercury fillings in their mouth. We find a lot of lead toxicity from our water supplies, especially well water. Chronic illnesses, decreased liver and kidney function, elevated cortisol, which is stress, that's their stress hormone. Estrogen excess, which we find a lot, especially in perimenopause and menopause. Women are still making estrogen when their other hormones are declining. People who spray their yards, spray their, houses with the pesticides. High carbohydrate diets, the American diet basically. Inadequate protein intake, oral contraceptive pills is one of the things. And one of the ways it affects it is it affects the selenium levels, but it also heavily affects the tyrosine levels. So you don't have as much tyrosine to make thyroid with. Selenium deficiency happens a lot under stress, starvation, again, those crash diets, and stress by itself. Aging, as we age, our conversion of T4 to T3 goes down. Taking too much alpha lipoic acid, so some of our patients will be taking this, over 600 milligrams can affect the conversion of thyroid in some cases. Too much calcium, hyperparathyroidism, which is a condition that can cause too much calcium also. And certain drugs, beta blockers, birth control pills, estrogen, Dilantin, and chemotherapy. iodine deficiencies and certain nutrient deficiencies. Diabetes is one of the things that will also affect this. So a lot of my diabetics have thyroid issues where TSHs look great, but they're not converting their thyroid. And then with the too many cruciferous vegetables, this is in the literature, but you got to really eat a lot of this to affect this conversion. Low carb dieting, low fat dieting, low protein dieting. So anything you cut out of your diet, you need carbohydrates, fats, and proteins in your diet. Soy is a phytoestrogen, so it mimics estrogen, so it causes the higher estrogen levels. And excess alcohol intake is another big one. And then fluoride and bromide. The reason for fluoride and bromide is because they affect iodine. So they displace iodine, so the thyroid does not have the iodine it needs. And then different toxicities. BPA is what you find in your plastics, like the plastic water bottles you keep on hearing about. Surgery. People who've had major surgeries and are very fatigued afterwards, sometimes it may have affected their thyroid. And then radiation. Any radiation that is in the chest towards the neck. Hashimoto's you may have heard of. This is an autoimmune disorder that causes low thyroid. One of the things that we first do with our Hashimoto's patients, obviously we measure their antibodies. We'll look for a source of it. Hashimoto's is usually triggered by something. Whether it's triggered by a GI issue or gluten is one of the things that heavily can trigger Hashimoto's. So we tell our patients to go gluten-free if they have Hashimoto's. It also can be triggered by trauma and infections. So we do look for those infections that can trigger it, and metals, especially mercury. The thyroid gland is very sensitive to mercury. So if people have just had their fillings taken out and they got some mercury released, that can also do it. So the antibodies we measure are TPO or thyroid peroxidase antibodies, thyroid globulin antibodies, and thyroid releasing stimulating hormone antibodies. The TRI is for Graves' disease, not Hashimoto's. And then thyroid resistance. This is the last category. Thyroid resistance, it happens very frequently in my insulin-resistant patients or my diabetics. It is the same receptors that became very resistant to insulin started becoming very resistant to thyroid. So this one's a very difficult patient to handle, because what happens is the receptors aren't working. So sometimes the blood levels look okay, but the symptoms are not. So we have to kind of chronically look at these patients and watch their levels and watch their symptoms at the same time. So how do we treat thyroid? Most of the time we'll use medications like Synthroid or levothyroxine. These are synthetic T4 medications. You can also use Cytomel, which is T3, so we can combine T4 and T3. We can also use desiccated thyroids, which are already combined. Desiccated or porcine thyroids or pig thyroid. The reason they use that is the pig thyroid is closest to the human thyroid that we can get, because there is no such thing as a bioidentical thyroid, like bioidentical hormones. So the desiccated thyroids like Armour, West Thyroid, Nature Thyroid have T1, 2, 3, and 4 in them, which is a lot more beneficial. So a lot of my patients feel much better on desiccated thyroid than they do on synthetic thyroid. Compounded thyroid, so we can actually custom make someone's thyroid. So, the reason for it is the desiccated thyroids come in at 4:1 to a 3.5:1 ratio. What that means is 4 parts T4 to 1 part T3. So Cytomel only comes in 5 micrograms or 25 micrograms. So if somebody needs 15, they have to take 3 5s. So we can actually custom make that dose to exactly what that patient needs if they don't fit the category of one of the prescription medications. The rest of them, Synthroid, Cytomel, Armour, Nature, West Thyroid, NP Thyroid, they all actually are by prescription and should be covered by most insurances. Compounded thyroid, because it comes from a compound pharmacy, is not covered by insurance. So how do you want to take your thyroid medication? So if you're taking Synthroid or desiccated thyroid, you want to take it first thing in the morning on an empty stomach. Because certain foods, especially foods with calcium, will block that thyroid from being absorbed very well. So we want to take it by itself. If you're taking any kind of calcium product, you want to take it at least 2 hours away from your thyroid. If you're taking a second dose of thyroid, so if we're giving a T3 dose, then that one doesn't necessarily need to be on an empty stomach. But that Synthroid or that T4 needs to be on an empty stomach for absorption. If you have low magnesium levels or are really highly stressed and your adrenals are very stressed out, if you take any kind of active thyroid like T3, some people may get palpitations, and feel like it's too much for them. And most of the time that's because of low magnesium levels or the stress system. So we make sure that those systems are compensated for first before we start those medications. It's not necessarily that the medication is too much, because I really start fairly low and build my way up. I don't give people high doses to start with. And that is the end of our presentation. If anybody has any questions, please submit. You're welcome, man. Thank you. I appreciate that.
Okay, so that's the ending that's up, or mic's off. And if you want to tighten back, you could. Let me put it over here.
You have a question?
How do you determine the source of Hashimoto's? Okay. You want me to get back on?
Yeah.
You want to do a live video?
Yeah.
Okay.
Yeah, just stay online.
Okay, well,
It's not up yet.
Okay. Am I good? All right, we have a question. This has to determine the source of Hashimoto's. So there's various different sources. The first thing I usually do is actually clean up their diet, make sure their gut's doing well. And then I turn around and do an infectious profile to see if they have Epstein-Barr virus, cytomegalovirus, mycoplasma, Yersinia, Lyme disease. Any of those can actually be one of the infectious triggers. And then if it's not an infectious trigger, it's not an intestinal trigger, we'll look at heavy metals and see if that's the case. So we start sorting through all the underlying triggers for Hashimoto's to see if they're there. And then we start correcting those triggers. So we clean up the system. And then we will modulate the immune system and try to get it to behave itself so we can kind of cut those antibodies down so the body stops attacking the thyroid. We also make sure that there's no nodules in there or any problems in there. So we usually ultrasound the thyroid on somebody with Hashimoto's. And I hope that answers your question.
Okay, so one said, thank you so much. I had a partial thyroid removal and now adjusting meds with a Cleveland Heart Clinic doctor, not adjusted yet. Ann Mara said, when should a person supplement with iodine and what type is best?
Okay, so as far as the partial thyroidectomy, what I find is when people have part of their thyroid removed or their total thyroid removed, they don't regulate very well unless they're actually given T3. Because the thyroid does make 20% T3, if they're not making any or getting that much in, they don't feel good unless we actually give them some form of armor, whether we give them NP thyroid, which is one of my favorites because it has less contaminants in it, or less byproducts. It's more of a pure system. Or compounder thyroid of some kind. So I do have a problem with people with thyroidectomies or partials without giving them some form of T3. I usually can give also Synthroid, levothyroxine with cytomel for them also, if that will work for them, if their doctor likes that better. As far as, what's the other one? Iodine, we will usually measure iodine levels, but again, if somebody's not converting, we can try a dose of iodine and see how they feel. But most of the time we'll measure the levels and see if they're actually low and they need them and monitor those levels.
Which foods do you eliminate?
The main food I eliminate is gluten. Gluten has a tendency in some studies to actually mimic the thyroid. So when people ingest gluten and they have Hashimoto's, it'll trigger the antibodies to elevate. So one of the ways we bring the antibodies down is through making them a gluten-free diet. The other thing we do is selenium and methionine. Since it is one of the nutrients necessary for thyroid conversion, it also seems to really reduce the antibodies to thyroid in Hashimoto's. So we use that to treat before we use any modulators. And there are several of those that you can use.
Kim Lawrence would like to know what other thyroid testing do you check? Just TSH or do you do a full panel?
No, we do a full panel on our patients. Initially, we'll do TSH, free T4, free T3, reverse T3, thyroid peroxidase antibodies, thyroid globulin antibodies, and ferritin levels to see if they have adequate iron stores. When we monitor, if they don't have Hashimoto's, I'll only check antibodies once a year to see if they're converting for any reason. Otherwise, I'll monitor with TSH, free T4, free T3, If they have high reverse T3 or we're suspecting anything, we'll recheck that one too.
Terry, is any initial workup covered by most insurance?
Yeah, most of these workups are covered by insurance. This is basic lab work onto LabCorp request.
Willow, when you say that you clean up the diet, he wants to know what you mean by cleaning up the diet.
Well, one way to know what you're eating so that we can kind of clean it up a little bit. So a lot of people are eating an American diet that has a lot of things in it. They don't realize what they're eating, especially if they're eating a lot of, fried foods, fast foods, processed foods, foods with a lot of chemicals in them. We'll go over their diet and kind of give them some suggestions. Lots of times when I take gluten away from the diet, I give them a lot of other choices. I show them what pasta is gluten-free that's good, what breads they can have that are good if that's really what they want to eat, where they can get their baked goods that are gluten-free that are really good. So we have a lot of choices to kind of help them do that gluten-free diet or dairy. Some people need to come off dairy. So cleaning up the diet means getting the things out of it that may be affecting your thyroid.
Is there any way to stop nodules from forming on thyroid?
It depends on the cause of the nodule. Some nodules are precancerous. A lot of nodules are iodine deficiency. Multinodular goiter is well known to be thyroid iodine insufficiency in many cases. So sometimes by getting the iodine replaced, we can shrink that thyroid down. Or if it's caused by infection, that would be another reason. Okay. Well, if there aren't any questions, thank you very much. Great questions, by the way. And good evening. I'll see you guys next month. I think we're doing hormones.